be available. The slide deck will be available and sent out by the program area. And when I talk about program area, I mean developmental services. So it's just around 10 o'clock. I think we should get started so we can go through the material, and then if there are questions, please put them in the chat or unmute yourself to ask your questions. Excuse me. So I just want to start off with a few definitions first. For those people that aren't as familiar with maybe the Medicaid enrollment process, this will give you an idea of some of the terms we're going to be using in the presentation. So when we talk about a provider, we actually mean a Medicaid enrolled entity that will be submitting claims for covered Medicaid services. The MMIS is our Medicaid Management Information System. That is where our claims are processed and adjudicated, and payments are sent to the providers. An NPI is a National Provider Identifier, and it's a HIPAA required unique 10-digit identification number for all healthcare providers in the United States. Revalidation is a requirement from CMS that when you enroll with state Medicaid agency, you are required federally every 5 years to complete a re-enrollment application. We have a process for that through the MMIS that is a streamlined process. So it's not that you have to complete the whole application at the revalidation, but there are certain components that you must enter into the application. Trading partner, that's a third-party entity that enters into a business relationship with the Medicaid provider to complete transactions. They also must be enrolled with the MMIS and have completed authorizations from each provider entity to act on their behalf. And the LEIE, or the OIG, as some people know it, is a list of excluded individuals or entities. It's a database of the Office of Inspector General. There is a website that I'm going to give you, and it's a searchable database, and you do not have to enroll to use that database. So we're going to start right out with the provider enrollment. Each service location is required to be enrolled with a provider type, and the new provider type that's being developed is developmental services. It's an online application, and I've given you the web address to find it. It is all done through our portal of our MMIS system. And then there is opportunity to upload documents that are required for the enrollment. One particular note I want to state is that they are still working on putting in the new provider type of developmental services. So when you start your application, if you start it now, you will have to put in the provider type as other. Because we do not have the new one active yet in the MMIS. But we want to give the opportunity to providers that if you want to start now, we will be accepting applications after this presentation.
Karen?
Yes.
I have a question. So if an agency does not want to bill, if they want to continue having the area agency on their behalf, do they still need to do this enrollment?
Yes. Because you have to delegate that you're going to have the area agency do your billing for you. That is my understanding. Now that could change.
Hi, Karen. This is Jen Doig. Thank you for the question. So, all providers that are currently providing services to individuals in the developmental disability system have to become enrolled. They will then be able to choose to either build a back office and direct bill themselves, or choose to pay or hire a third-party biller to do their billing on their behalf. And that third-party biller could be an area agency if they so choose to be a billing provider. So that's how it's going to work going forward.
Thank you, Jen. Did that answer your question? Were there any other questions?
Hello, good morning. I have a question for Jen. So Jen, when you said that, when you reference as a provider, are you referring to the provider agency?
All they're vendors. Provider agencies are vendors. Currently in the developmental system, there will no longer be vendors. You need to become enrolled as a Medicaid provider and go through the system that, like Karen is talking about.
And we do have an option to directly bill Medicaid instead of going through the area agency.
And
correct. You will have that option.
I'm going to get into that option as we get through the application part. I've split that out on a slide for you so we can talk more about it at that time.
Jen, I have a question.
I have to just decline this. There we go. Okay.
I have a question. Jen, you just said that if we don't want to bill ourselves, we can pay another company to bill for us, and that company might be an area agency. So
if they choose to be.
Are you saying that we're now going to have to pay the area agency? They won't do it as part of their dad's business?
That's correct. So every provider will have the option to direct bill. They can do it themselves or have Karen, correct me if I'm wrong, it's a trading partner that they will list.
So we're going to have to pay the area agency to bill for us if we don't want to bill ourselves.
Yeah, which you currently are doing now with the budgets that you present, because they keep a portion of the budget.
Oh, okay. Okay. But it won't be an extra charge.
Well, the budget system it'll be different the way a budget is developed, because we'll be having rates, but you will be getting the rate that the state has set, and then you will hire, instead of negotiating a rate that is probably lower than what the state rate is and having them do it.
Okay, thank you.
So that is all going to come out in when we do the next modeling. So I think today we really want to dedicate it to, instead of talking about that, let's listen to Karen and Conduit in how to enroll, because everybody has to enroll. So let's work on that now, and I'll let Karen do that. Hold the other questions, send them to Jess Kennedy after the meeting, and we'll collect them and we'll work on that at our next meeting. And by the end of this month, September, beginning October, we're going to start the modeling. So more will come out with that. Okay?
Okay. Thank you.
All right, Karen, I'll let you go through. Why don't you just go through it, and then because if, we just want to let you have the time that you need.
So as Jen said, in order to be an enrolled provider, there are some functions that you have to complete. So this is in order to bill and get paid for Medicaid covered services, however it is set up. And we'll go through that in a few slides. So a provider needs to complete the application online, and we gave you this list that needs to be included with that application. These are all forms that are found on the MMIS enrollment site, and it's a signed provider participation agreement. It's a signed application signature page. It's a copy of licensure if required for certain agencies, a copy of a signed W-9, an IRS verification letter, and a Social Security number verification. If you are going to be billing with a federal tax ID, you must complete the billing group application underneath that provider enrollment list. If you will be billing with your Social Security number, you must complete the billing individual application. Now, what I came up with a sample for that is if you have someone that is doing an environmental modification and they are a sole person, a sole individual that you are engaging an agreement with for them to provide a service for one of your Medicaid recipients, they may only have a Social Security number because they don't have a group FEIN number, tax ID. So that would be an instance that you would have that person become enrolled. And if that is a person that is going to be utilized to provide multiple services. And that was the distinction I was trying to make between a group and an individual. All of the applications must include a 10-digit national provider identification number. And I get into how to do that in another slide. As well as it's called a taxonomy that identifies the services that you're providing. We put a little note here about a best practice that when you are submitting your claims and you're using your NPI number, it is in the best interest to also include your provider ID as well. That way we can ensure that it's going to the appropriate entity. In the application process for a group provider, there are sections that must be completed in order for us to move forward with the application. And one of them is the owner and managing employee section of the application. Now, what this means is it's kind of confusing the way the questions are worded, but an owner of your entity. Is there a sole owner? Is there a shared ownership? Is there controlling interest in multiple owners? Or do you have a board of directors? That's the section that you would fill out under owner. If you are going to complete the managing employee section of the application, that means your day-to-day functioning people. Do you have an administrator? Do you have a chief executive officer? Do you have a chief financial officer? Those are classified as managing employees. And those also would have to be disclosed on the application. That is so that we can do our federally mandated comprehensive screening. If we do not have that information on the application is going to be stalled while we try to obtain that information from you. You also need to complete registration for web access. This allows the provider access. You can check eligibility of members, you can submit claims, and you can receive a remittance advice. The provider also must keep copies of appropriate service provider qualifications. That would be a licensure or documentation of credentials on file. This is for all non-enrolled staff so that they can be screened monthly by the provider, which is you, on the LEIE OIG exclusion site for any sanctions or exclusions. And I gave that presentation over a year ago to the area agencies about it is a responsibility of enrolled providers to check all of their staff on a monthly basis and maintain a copy that they are doing that screening in case of an audit that would be presented to you. All providers also are required to revalidate every 5 years, as I said, by completing a new application and submitting signature pages, and then we complete the screening. Now, if you are an enrolling group provider and you've given us the owner and the managing employees, we do the screening at the state and we do the monthly checks. That is how the state is functioning right now, so that the provider is not burdened with doing all of those. The state will take care of that for you. Okay, here we are with the NPI. So the National Provider Identification Number is all individuals and organizations that meet the definition of a healthcare provider. Sorry, this is interrupting with my slide. As described at 45 CFR 160.103, are eligible to obtain a national provider identifier. These include health plans, health plan clearinghouses, healthcare providers who transmit health information electronically, and healthcare organizations that transmit protected health information to covered entities who require access to the protected health information. Basically, this is a part of HIPAA. And it is required that you have that MPI number and that you use it on your claim submissions. NPES is the National Plan and Provider Enumeration System. That is where an individual or organization must submit an application in order to obtain their MPI. There's also a website that you can go to obtain or to check your NPI number. If you already have an NPI, this question came in prior to the presentation, and you are using an NPI for multiple services within your organization, that is the provider's right to choose an NPI that they desire to use. But when you're doing your claim submission, it is in your best interest to put your provider ID on your claim as well, to ensure that the remittance goes to the correct entity. That is, because there are some agencies that have multiple levels within their agency, and that just ensures that the remittance goes to the correct level that you want. Now, we have been doing a preliminary review of all service provider qualifications, and I did not have that completed for this training. That will have to come at a later date. We are categorizing services into specialties, and it will identify qualifications that each specialty needs in order to have that specialty listed under your provider ID number. We have a mechanism within our MMIS that we can do that. So if you are providing multiple services, we have the ability to put those specialties underneath your provider number so that it does say that you're eligible to do those services. We've looked in the state plan, and we are also looking in the administrative rules. And this is regarding the licensure requirements specifically. So at this time, in a preliminary look, it identifies that case management only providers may require a health facility license. And that is what our preliminary review has discovered for us. Now, we have not made a final decision on that yet, and we will be determining that and sending further guidance out from the department when that decision has been made. But that is the preliminary review about obtaining a license for case management only. Okay, here we go with claim submission and payments. So you've got your application done, and now you need to make a determination on your claim submission and payments. Excuse me one. In order to be paid electronically, you have to complete the enrollment application. Section 4 is the electronic funds transfer section of the application. And in order to do that, you have to submit the following documentation: an EFT agreement form, an EFT application form, and a bank letter or copy of a voided check. We've identified there are 3 ways that you can submit claims for payment. The first would be you actually will have access to go into the MMIS portal. And with this process, the electronic claims are submitted directly into the portal and receive real-time adjudication. So you'll know if they've been accepted or not. Conduent does offer a group training session. Excuse me. Or they can set up templates that you can use if you want to do this submission of claims. Sorry. There are 3 ways. The second way is the vendor software. This is if your entity already has a third-party vendor software that you use in your agency to submit your billing to other entities for payment. You may use that third-party vendor software to submit to Medicaid, but you must submit the following documentation: an electronic remittance advice application, and this is required for all 835 transactions, which is your remittance, and a trading partner signature page. Now, I know it says trading partner there, and you're going to use the software, but the reason we have to have that trading partner signature page is we have to know what the software is that you're going to be using, and it has to be tested through the MMIS system so that we ensure that you have appropriate transactions going back and forth following the HIPAA regulations for those transactions. Trading partner. This is when you're using a third-party billing agent. The billing agent also needs to be enrolled. So if you are not using an area agency, but you are using another third-party billing agent, they will need to complete and be submitted and obtain a trading partner ID. It is a unique ID that they use, and they also have to submit the following documentation: the electronic remittance advice, a billing agent agreement form, and a trading partner signature page. Now, the reason we require those is to make sure that the provider who wants to use this third-party billing agent or the vendor software, that we are aware of what you will be using, and it becomes a part of your enrollment record. And we also ensure that they follow the HIPAA regulations for that billing, and that their interaction with our MMIS meets the guidelines that we have in a compliance guide. So they do have to usually go through some testing with the MMIS to make sure that there is no problems with them receiving remittances from the MMIS and us receiving claims.
Karen, this is
Now-
Kathleen. Can I just interrupt for a minute? On the trading partner, that those forms are going to be submitted by the provider that is enrolling. Okay, so just so that you understand that in your enrollment, those can be uploaded in your enrollment, original enrollment. Those are the forms needed if you're using a trading partner.
Okay, that was Kathleen Donovan. She's from Conduent. And those are that the provider themselves have to complete those forms that you're designating to the third-party billing agent. If a provider determines not to continue with a trading partner, say that you change your mind and you do not want to continue that relationship, a letter from the managing employee of the provider needs to be sent to MMIS informing of the change.
Karen, we can't hear you.
I'm sorry, what was that?
We couldn't hear you.
I know, sorry. So now I'll stop for a minute. Are there any questions up to that point?
When is this required to be done by?
We have not set a final date yet. We are presenting this today, and we do not want to hold back from providers if they want to start the process. So we are going to be able to start taking the applications when the providers are ready to start submitting.
Would you be able to share this PowerPoint with us so that we can reference it as we go through the process?
Yes, as I said in the beginning, this slide deck is going to be available to everybody that is participating within this project. So even if you're not on the call, you have an opportunity to have a copy of this.
Thank you.
Any other questions at this time?
So I have a question.
Mm-hmm.
So we do early supports and services. We also do community-based services. So, for example, we've got 2 different offices for the early intervention, early supports, and then we have like 3 offices that do the community-based services. So does that mean I'm looking at making 5 new group IDs? Or are they all going to be like, can we put 5 locations under one that is developmental services? Or are we splitting them half early supports and then putting the CBS under one?
So, Mark, according to the regulations, we can only put 1 location under one
Okay.
application.
All right. So every location we'd need an ID.
Mhm.
And then as far as the NPIs, so can we, if we have existing NPIs, can we use them for, you know, like, so for example, our 3 community-based services, can we use that same NPI for each location?
Are you currently using that now?
Well, we're not really even billing the CBS, but we are using, so for example, our early supports and services, we have also like, so we have 2 outpatient IDs, one for each location. They use the same NPI right now. And if we could keep that NPI and port it over to these new IDs, I don't know if that's what we want to do, but I'm just posing the question.
So I'm going to say that is a decision within your organization, how you want to handle your NPIs and your provider IDs. We at the state level we do not direct how you do that. We kind of tell you the pros and cons if you ask us the question. So if you use an NPI for all of the services that you're providing, it may be difficult determining what you're getting paid for.
Okay. And then another question. So for the community-based services, we have like residential, like EFC housing, right? So there we have group homes, and we have, you know, individual families that host these clients. Are all of those going to be considered locations that require a group ID, or are those going to be sort of rolled into the office locations that are managing those?
They're going to be rolled into the office location. Yes.
Okay,
That's
great.
your specialty that we're going to put underneath that location. Mm-hmm.
Okay, that's all I got for now. Thanks.
You're welcome. Does anybody else have any further questions before we go on?
Just to clarify, each location will have to do a separate application?
Yeah, if you have the only way the MMIS can set up the provider ID is by one location. It is a challenge to set up multiple locations. We don't have the capacity to do that. I think prior in old versions or something, there was some different mechanisms, and I know Medicare sets it up differently than we do, but our system can't handle it. So we can't list multiple locations underneath a provider. So we have the main location and we have the service location. That's what it is on the application that you will see. So if you have a main office that's going to be doing your billing and your coordination and those types of things, that would be your main mailing address. But say your service location is at another address, you would have to list both. Mailing and service.
Sorry. So we have offices, but we provide our services in people's homes for enhanced family care, adult foster care. So one office might serve 30 people, but the services are actually occurring in their homes.
That's okay because you use the office address. The office would be your location address.
Okay, thank you.
Because you provide community. So you don't actually have another office. These are for people that have multiple offices throughout the state. It's difficult to determine which office is which. And when I get into the screening requirements, there are some requirements that we consider we have to do. We have to follow for the federal regulations where we have to make a site visit. So we would have to know where we were going.
So we have 4 offices throughout the state. So we would do an application for each office as a community provider of community services from that office.
That is the current status. If that changes, I will let you know.
Thank you.
Mm-hmm.
Is it possible that this will not occur this fiscal year? Like in terms of turning over the billings and having, not the application, but the actual implementation?
The application is going to happen this fiscal. I'm
Right.
not sure about the other part. I'm not as involved in that, and maybe Jen can give you some timeline on that. But the reason we wanted to do this today is so that people have an opportunity to go in, look at the application, and start looking at and deciding how do you want to move forward with your services and be reimbursed. Am I accurate, Jen, on that? Did she drop off?
Jen just dropped off. I can touch base with her on that.
Okay, Sandy, am I accurate on that?
I'm sorry, Karen, say that one more time.
Oh, okay. So the question was, they wanted to know if this was going to happen in this fiscal year. And I said that the application process is going forward in this fiscal year. But as far as the other determining factors for the billing components, we wanted everybody to have an opportunity to at least go forward and complete the application and get it in. So we would be
Yes.
ahead of ourselves.
Yes, that is true. And keep in mind that the modeling, and we're still going to do that modeling, and that information we will take, and that could change some of what we are thinking at this point. So, you know, that's why we're doing the modeling. So stay tuned on that, but getting a head start on doing getting your applications in, getting your provider numbers, becoming a Medicaid enrolled provider is to be done now this year. Yes.
So, and it doesn't, as long as you start your application process and we get you screened and get you a number and everything, it's not a written in stone application. You can always make changes down the line, especially to specialties and other things that are going to be assigned to you. We're going to be looking to the program area, the Department of Developmental Services, to help with that, because they all know what you are providing for services by service authorizations. So we are going to be looking for them to assist us with what specialties we're going to be assigning certain providers. So this is sort of a whole collaboration process with all of us going through trying to start this. So
Now, I have a question.
Yes.
So if a vendor agency were to submit the billing directly, there are functions which the area agency does on behalf of the vendor agency in the current setup. What responsibility then falls on the vendor agency if they were to do direct billing?
If you are going to be an enrolled Medicaid provider and you're going to be doing the direct billing, then it solely is your responsibility to ensure that you are billing the correct codes, the correct amount, and checking your remittance advice to see what exactly was paid for you, as well as providing your services, whether it be you include case management in that or just your services.
So the case management, if we were to directly bill, then the case management would not be there for us in that instance?
That is, my understanding is that is a choice of the individuals. Am I true, Jen, in that?
Yes, individuals will have a choice.
Mhm.
That's the corrective action plan, the conflict of interest. They will have a choice to have an independent or an area agency. If they choose an area agency to do their case management services, the area agency cannot provide direct services to that one individual.
So in an event when the vendor agency is directly billing Medicaid, we would still have area agency if the client were to choose area agency involved for case management.
Yeah, that's correct. So they could choose an area agency to do their case management, but now you are a Medicaid provider, a standalone entity providing a service, so it's no longer a conflict.
Correct, but our understanding was, the percentage which the area agency gets out of an individual budget pays for case management. Would we have to then pay the area agency for case management?
So the way the system is going to work with direct bill, there's a rate. So the rate based on the service agreement, so the budget template as we know it will no longer be. Service agreement will direct where the services go. So that case management, so they're going to choose Lakes Region to do their case management, making this up. Here's the rate for case management. That's what that individual will be getting. Then for you, the service that they provide for you, that will be part of a PA. That'll be a line item on the PA. And what level it is, that's the rate you get. That's based on our rate table. And that's what you get for the number of units that you request and what the service agreement determines that individual needs.
Jen, this is Anna Lake. My understanding is this does not apply to early supports and services or to early supports vendor programs at the area agency.
Hi, Anna. Which doesn't apply? Becoming a
Service
Medicaid
coordinator conflict of interest, because that service
that is correct.
provided right within the scope of
That's correct. It's the conflict of interest, the corrective action plan is with CMS and our waivers. ESS is not a waiver program. It is a Medicaid program. It's not a Medicaid waiver program. So, but providers of ESS should enroll as a Medicaid provider.
Is every program type going to have a rate? In other words, enhanced family care will be a rate, group home will be a rate, day hab will be a rate.
We currently have a slate of rates for day hab. We have six rates
Right.
in the DD system for
But enhanced family care is budget based on the individual, as are most residential setups.
that's true. And so we will be shifting.
Jen, this is Lori Vashon. Enhanced family care won't have a separate rate from a staff. What we pay for are residential services, and the level of care of those residential services are the rates, not how they're implemented. So I want to be careful about that. So there's rates for residential services, but not necessarily a special rate for shared family living versus staffed. It's a residential rate depending on the needs of the individual, and how those services are provided depends on the individual and the team.
Thank you, Lori. Yes, that is true.
So how many rates do you anticipate, since needs are very varied? Is it high level need, medium level need? Is it behavior, diagnosis?
We are still working that through. And we will be using area agencies as well as our internal staff to determine what we can use as a basis for what rate.
And who decides on the rate?
Currently, the system has had rates for many years for different levels that the area agencies have been using. And a lot of times it's based on the assessments. But there will be a few shifts in the number of days for residential that we've talked about before. So when the modeling comes out, the rates will be shown for people that are doing the modeling, and it will all be described how it's going to change. So for example, residential, or I should say personal care. It's residential personal care. It's really personal care services that are provided. It'll be on a 365-day basis. For DD and IHS, they can have 52 therapeutic leave days a day that the state will pay for. That's what it is for our institution on the state plan. And from CMS, that's all that we can have for therapeutic leave days, bed hold days, however you want to call them. For ABD, they have a nursing facility level of care as their ability to get waiver services, their eligibility. And so they have 30 days of therapeutic leave. There will no longer be budgets based on 313, 185. It'll all be on 365, and it will be by the rate. So instead of having a total dollar amount and backing into the rates, what's going to happen is, based on the service agreement, you're going to be listing the services that are needed by the individual with their frequency, number of units, as well as the rate based on the level. Some respite, they don't have different levels. And then you pick that rate, and that's what you get. A little different.
So thanks, Jen. Are there any other questions?
Yeah, Karen, I've got a question. I'm just not clear on one thing, because we've kind of moved away from re-enrolling to rates. So I just want to make sure I understand. If we have one location but multiple services within that one location, do we need individual Medicaid numbers?
No, not if that one location is your service location and you're providing services in the community. That one location would suffice as one provider ID.
Good, thank you. Thank you for the clarity.
You're welcome. We do know that this is why we wanted to start this early, because of these concerns that come up and how you provide services. We wanted to make sure that we gave everybody the opportunity to be enrolled in the correct way, and not provide a burden to you trying to complete applications and maybe they weren't needed. So if you have any questions when you start your enrollment process, please reach out. We have a multiple of people that are going to be available that can help you with these questions, as well as Conduit, myself, and the program area, the developmental service area. So I want to talk about federal screening requirements, because this is the basis basically for why the state does an enrollment process, is that there must be program integrity screening, which is my area, and that there's a whole section of the application called Section 7 that talks about exclusion and sanctions. This section has yes/no questions. And if any of those questions are being answered with a yes, It is the responsibility of the provider to send in backup documentation regarding that. If you have not seen one of the applications, I suggest maybe going onto the website. We have an instruction manual for enrollment, and you can actually go through and you can see what the questions are. So those questions must be answered. They have to be completed for the application to be a complete application. When those questions are answered, that gives us the insight to doing our federal screenings. We have regulation regarding our in-state and out-of-state providers that if you are already, say, enrolled with Medicare, or if you're enrolled in another state Medicaid agency, that we do take those screenings that have already been done. But most of our providers enrolling in New Hampshire Medicaid are not enrolled in another program unless they're a Medicare provider. So we have to do those screenings as required, and they look for those screenings when we go through an audit. The screenings are done on the provider group, as I said, the ownership and managing employees. It's the provider's responsibility to screen all of your employees that you use. And that means that you make sure that you have the proper licensure of certification, and the OIG screenings are done on a monthly basis. If you happen to contract with any individual to provide covered Medicaid services, those screenings are still your responsibility to make sure that they're done on that person. And I go on to talk, because I use this for other entities, but also there are some entities that use outside professional groups. They have to also make sure those screenings are done either by the group or by the provider themselves. And the rule of thumb is that you should perform these screenings upon hire of an individual or entering into a contract, and every month thereafter until the provider no longer employs or contracts with the person. You're required to search the employee or contractor name on the OIG list of excluded individuals, and it's a website that you can do a search, and you are to validate that they are eligible to receive funds from federal programs. That is the purpose of the screening, so that
Karen?
federal, I'm sorry.
Hi, Karen. It's Anna Lake again.
Hi.
I guess I'm looking for clarity, because it feels like a lot of times when we have trainings for the area agency as a whole, the focus tends to be more on adult systems. So how does this apply to early supports and services with the contract providers that provide, you know, whether it's autism services or whatever, hearing and vision?
It's the same.
So we have to, the provider, Medicaid provider, the vendor program contracting must.
The person who's providing the service
licenses and
not an
screen them?
individual. So, Anna, if you have if you have a contract or an agreement with an entity that provides these services for you, that entity is supposed to be screening their employees on the OIG excluded list.
But we also have to verify that the screening has.
You have to ask them, are you doing your monthly screenings on your employees? And they have to be able to show you that they are.
So it seems like it would make sense that that be built, some language be built into the contracts around that.
I think you should. Most of our providers and our other side of the house do have it in their professional agreements that it is the contractor's responsibility to make sure the OIG screenings are done on their employees.
Okay, thank you.
Karen, this is Diane Bolduc. Could you give us some indication of what are the criteria for excluding individuals or entities?
Okay, have you ever gone on the OIG website?
I don't even know what OIG stands for. I'm ESF.
Inspector General. Okay.
Thank
So it's the Office of Inspector General, and what happens is these individuals or groups have been sanctioned by the Office of Inspector General or excluded, that they are not to receive any federal funded monies. That means the entity or the individual. So it would be, say you, there was an RN that was excluded on this list, but yet that RN came and wanted to be employed as a personal care service provider. Well, if you check the OIG list, her name and social security number are going to pop up. And that means that it says right on the list that she is an excluded individual. So you actually cannot use that individual to provide services that are being paid by the Medicaid program. Or
So my question though is, what would cause a person to be excluded?
There was activity, whether they overbilled, false claims,
Okay.
bill for services that weren't provided. We have other entities in other states that, because each state Medicaid program is different. So we had an entity that practiced in California and was convicted of a fraudulent activity, and they were put on the excluded list, and then they tried to enroll and provide services in New Hampshire.
I understand now. Thank you very much for clarifying.
You're welcome.
It's not tied into Corey.
Karen, one more question, building off what Diana just mentioned.
Okay,
So what happens with contracted staff that are not enrolled as Medicaid providers because they just do contract where we just pay them?
yes, but it is ultimately your responsibility hiring that contracted staff that you ensure that they are not on the OIG list.
I think, Anna, that's because even though we're paying them with Medicaid dollars.
Correct.
Hi, Karen. This is Sudeep. I just have a question. I just wanted to go back to Frank's previous question. When you said that, there might not be a need of, applying for multiple provider IDs. I was just thinking, what if the vendor agency is providing both DD and ABD waiver programs? Isn't there a need to be, applying separately for DD and ABD?
No, that was the purpose. Thank you for the question. That was the purpose of developing one service provider type of developmental services, so that you wouldn't have to do multiple applications for different service groups.
And Sudip, this is Jen. You will be able to distinguish that by the billing code. So our billing, the procedure codes and modifiers already distinguish between DD, ABD, IHS. So by just having one provider number, you can still provide all those services and bill for those, and the billing codes will take care of themselves, which is really why we have them that way.
Thank you, Jen. So, so is this something that area agency will have to re-enroll with, Medicare provider, application?
Yes.
Thank you.
Is there any more questions on the exclusions and the list and what the responsibilities are?
My question on the exclusion is, does that information also tie into things like Corey, the criminal record checks in New Hampshire?
This is federal. This isn't state. So
one's not connected to the other.
It is not connected. This is federal across the 50 states. So if something happens in one state, it is identified on this list. If you're trying to engage in somebody working in New Hampshire that maybe had a violation out in another state.
And it's not necessarily current because it's not allegations, it's proven.
It is current. It's a daily feed that goes into that list. It is huge, huge. So these are all convictions, you're correct. So if there's an allegation and they have not been convicted, then they may not be on that list.
Hi, Karen. Just one more question, and I'm sorry. I
No.
feel a little naive with this.
No, I'd like everybody to understand it because I know it's a lot of information for some people. So go ahead.
And I understand that it's, that we're paying them with federal funds.
Yeah.
If somebody that we're contracting with is not a Medicaid enrolled provider, how could their name possibly show up on the OIG as being exempt?
Well, we're hoping it doesn't, but they don't have to be an enrolled provider because the OIG list is all individuals and groups. So if the person named, like we have a case that was down in Massachusetts that a person was named in falsifying claims for transportation. It was an individual and the person was named into the False Claims Act and the person is now excluded. They cannot receive any Medicaid funds, period. Because it goes by their social security number, the individuals.
Okay, I think I get it now. Thank you.
You're welcome. Any other questions?
Karen, I just have a question around the OIG list. We currently, this is actually a requirement by the area agencies, and as a vendor agency, we do the monthly screening and we do a quarterly attestation that this is being done.
Yep.
However, the list, what we get from the state website, it looks specific to New Hampshire, and it's not a very big list if it were to be like a federal list.
Correct. So you are doing the state of New Hampshire list, which Program Integrity has posted on the website of DHHS. Correct. You need to be doing the federal list, which is the Office of Inspector General.
Okay, so the list will change. Okay.
Yep, you should be doing a bigger one. Okay?
Thank you.
All right, we're going to go on. So this answers some of your questions that you've already asked, but if the provider finds that you have a sanctioned individual, a nurse, for example, that is now trying to work as a personal care service provider or be an enhanced family care provider, then you need to discontinue using this provider. As soon as you find out that that person is on the excluded list, you need to discontinue use of that provider. Only the individual or group can change their status on that list. Nobody else can intervene and change their status. It also needs to be immediately reported to the New Hampshire Medicaid Program Integrity Unit. And usually the information is just brief. You can send a secure email and you send it to our Program Integrity email box, or you can mail it in to the Thayer building. And that you cannot continue using that provider. That is the process until that provider clears themselves or there are changes made that it was done in error by a wrong social security number.
So Karen, this is Jen. Let me just clarify that currently this is what needs to happen for all Medicaid providers now. This is not something that is a future thing. So this is something that has to happen now. So
right.
The area agencies, it's their responsibility to make sure that this is happening as well, or anyone that's enrolled as a Medicaid provider. This is current and has to happen.
So if you are providing services to any of our Medicaid members, and even though you're not enrolled in Medicaid yet, you should be screening your employees on the federal OIG, Office of Inspector General list every month. Okay. So what happens after you get this enrollment completed? Now you've gone through all this, you've submitted all these forms and everything, and we've done our screening. You receive your welcome letter. You now have your new Medicaid provider ID. Your responsibility after you enroll is you need to keep the information current. We have multiple providers who are delinquent in sending change of addresses, change in board of directors. They don't, change in ownership, managing employees. They're not submitting appropriate change forms for authorized representatives to have access to the portal. All of these things will affect your ongoing day-to-day management of however you choose that you're going to be paid for claims. And it's going to affect if you want to do eligibility checks in the system, but your authorized person is no longer with you and you didn't submit a change form to change that, then you have no way of checking eligibility of Medicaid on members. If your board of directors, ownership, managing employees change, that is a huge effect, because there are times when certain providers go through what we classify as a change of ownership. That change of ownership is supposed to be submitted to the state of New Hampshire within 35 days of that change. And that is a very cumbersome process for us to backdate and recover claims that were paid on a provider ID that's inaccurate. That is a perm error for us, which is, that's our error rate with the CMS. They do oversight and auditing of our enrollment activities. So we try to make sure that we instill upon our providers, it is important that you keep us abreast of any changes going on in your organization so that we can make sure we have the most accurate information. I know sometimes it gets missed, and that's okay. But when we do revalidation, we send out a series of 3 letters telling you your revalidation is coming due. We have a volume of providers that we don't even know if they got those letters, because we don't think the information we have currently in the MMIS is their active address at this time. So any service location address changes, anything like that, really needs to be reported to us so that we can make sure that we update your files. Now, if you're not sure it's a reportable event, you certainly can call the Medicaid Provider Relations Center and they will walk you through that and help you understand. Also, if you are accepting 835 files, which are your remittance files, if you have checked off that you want to get them and you know they come a certain day every time you submit claims, if you don't see those files coming through and within 2 to 3 business days of the projected date you're supposed to get it, you really need to identify Medicaid Provider Relations, because maybe there's something wrong with the way the information is being fed back to you, or there's a delay at the MMIS system and they didn't get them out on the day they were projected to go out. So if those files are missing, you really need to call in and find out if everything's okay. You also need to maintain staff files at your provider locations. It doesn't matter to me that you choose your main location and all of your corresponding information is there. It's fine. It's however you as the provider wants to set up your staff files, but those staff files have to be maintained with all the current information for that employee, including your screenings that you completed. And there's more than the LEIE, but I did not include them all here as I know each entity has different screening requirements. The last thing I want to say is, for any questions, please reach out to the Medicaid Provider Relations Center. I've given you the number and the availability here. Reach out to Michelle Rosado, Reba, Laurie Vashon, anybody within the program area, Jen, Sandy, anybody that you normally send your questions to. If you're having any difficulties or struggling with the documentation or the MMIS portal, just reach out to us. And Program Integrity we have an email box that you can certainly send emails to with questions, but don't try to do the struggle with the application and the process that we're talking about without reaching out for some direction, because we'll be more than happy to help you and try to get you through this process. That concludes what I wanted to talk about today. I know it's been a lot of information. I know that, you know, this may be new for some people, but that's why we're going to provide this slide deck so that you have it as backup information. And now we'll open it up and we'll take questions from the group.
Karen, just wondering if you can include the email and the names of the specific people as well.
I'm sorry, can you repeat that?
When you email this information out, can you include the names of the contact people you just provided, Michelle Rosato and all them?
Yes, we will have a slide. I did not provide that. I didn't have all the information right at my fingertips. So we will provide a slide of contact information for you, yes.
And I think it'll be important to work through the liaisons, area agency liaisons, and plus the other people that Karen had mentioned, and we can get it to the appropriate people.
I have a question about individual providers.
Yes, Mark.
My assumption so far is that for like our adult services, none of these, you know, support staff or anything are licensed, you know, so we would be billing under the group.
Yes.
For the early supports and services, we also do outpatient. So all of our physical, speech, occupational therapists, they all have their own, you know, non-billing rendering IDs. Are we going to be billing those ESS services under a group ID, or are we going to be applying the rendering provider ID as well as the group ID? And if that is the case, then we have, you know, like educators, you know, certain hearing, vision specialists that don't have their Medicaid IDs. Are they going to need some kind of individual rendering ID?
Are these services provided to school-age children, Mark?
No, so these are under three,
Under 3.
early support and services.
Okay, so you'd be billing those services as a group.
Okay.
And you're contracting with those or having an agreement with those people to provide those services to your under 3 population, correct?
Okay. Yes.
So Jen, how would you see that happening? I don't see that they need to enroll all those individual people because the group is billing for the service.
Okay, Karen, you know, we work directly with you and with your experience, so I will.
Because that's how we do it in the school.
Yep, exactly. We're not looking to reinvent the wheel here.
Yeah, that is a large undertaking.
Yes.
If that's going to happen. And
well,
we
and
do it at the school level right now for those.
Right, and two, we're not looking to lose providers in this process. So, yes.
So this is Kathy Gray, Part C coordinator for the ESS program. Currently, the services for the ESS children, the 0 to 3, is a bundled billed service.
Correct.
I don't see needing to identify each one of those providers if the program or the area agency is registered as a Medicaid provider.
That is correct, Kathy. We are saying that you do not have to individually identify those providers if you are going to be billing that one bundled service that is encompassing. We know by the code of the service that you're billing for what you're providing.
This is Diane Bolduc, also with ESS. I have 2 questions. Are the ESS employees still subject to, and are we required to do the OIG process for them? And then the other question is, will the bundled rates, will we still be using bundled rates, and or will they be changing either the rate or the way we do that?
So yes, you're still subject to the OIG screenings of employees. So if you have those employees that are providing a service, then yes, you must have them screened or you do the screening.
Okay.
And as far as the bundled rate, I am not involved in that. That's Jen. And right now, that is the coding that we have in place for that service. So
Okay,
Jen,
and
that
then-
would be your.
Okay, and then the other question is, currently we built a variety of things under service coordination, one of which is intake. And we're only allowed to bill one service coordination a month. So if the area agency is doing the intake on May 2nd, and the first service winds up being at a different program on May 30th, and they're providing a service coordination as part of writing the IFSP, would only one of those be billable? And how is it determined which one gets to bill that?
Diana, that's a very good question. We are working with Kathy Gray and Dee, and the area agency is working through the different tasks that are involved in the DD, ABD, and IHS waivers, as well as case management, and for in the ESS program, the EI, the family support, and working through the funding that goes with each one of those tasks and see what the delta is. So that's still a work in progress, but I appreciate you sharing that information.
Okay, thank you, Jen. I'd appreciate being apprised when you've made when you're making decisions or progress with that. Thank you.
We will. This meeting, we wanted to leave it for enrolling and letting Karen explain like the OIG, what needs to be done, what is behind it, why they're doing it, as well as our MMIS partner helping send you to the forms and direct you through that, because this is a very important process and a change in our system. Starting next month again, with these meetings, we will start talking about that more and share as we come up with information.
Great, thank you.
Yep.
Yeah, Jen?
Yeah.
I want to add on that in addition to the intake sort of duplication of service coordination that we run into with early intervention, we also have that happen with family support services. So the programs, the early intervention programs provide service coordination under ESS each month or most months with the child. Yep. But when the child also receives family support from the area agency, we don't have the opportunity to bill for that.
Thank you for that. I will tell you, the group that we have does have 2 area agencies on it working with us. So I believe that has been identified as a task under family support as well.
This is Karen. I just want to go back to your NPI and your taxonomy. I want to make sure that it is understood that if you do not have an NPI, you will need to get an NPI through the NPI website. Also, when we talk about taxonomy, that identifies you as a provider. So they have taxonomies out there that are community services, home health, medical service clinics. There's all different taxonomies. So you will need to pick the one that appropriately identifies your service location for services. So if you're doing primarily community services, you could look at those types of taxonomies and select those. That is part of the registration when you're going through for the MPI. And I might have just sort of moved right over that quickly, but I wanted you to know that that could be a question during your NPI enrollment, that you will be asked to select a taxonomy. And you should have a taxonomy to complete the group enrollment application. So, any other questions regarding the process or the reason we wanted to get this out here now is we were hoping that this would give you providers an opportunity to start looking at the group application and you can certainly go ahead and fill it out. We have a workaround process. The new developmental services provider type probably will not be activated until October, but we can take your applications now and start looking at them for, you know, the any items that are missed or any issues that arise with them.
Hi, this is Deborah DeSenza. I have a question regarding contractors. So if we were to enter into a contract with, say, a speech language therapist, I understand we'd have to run them through the OIG, but do we have to get, or do they have to have an NPI and Medicaid number, or we just...
We do not actually at this time identify rendering service providers in Medicaid. We identify ordering and prescribing. We have those enrolled in our system right now as what they call an ORP. You do not, if you are going to be doing the billing for her services, you need to maintain the information at your office regarding that provider.
Hi, this is Kathleen.
Okay, thank you.
Yeah.
It's referring. We don't require the referring. We do require the rendering.
Well, we don't ask them to enroll though. They don't have to put them on the claim.
Okay.
Yeah. We do have some edits in the system that will pop up on claims. So if you have any of those questions regarding whether you should identify them or not, please reach out to the provider relations or to program integrity.
Thank you, Kathleen, for bringing that up. I appreciate that.
Yep.
I have a question similar on the same line. So we, as service providers, we work with other entities who provide something like a behavioral services. And can they go through this process and directly bill for their services for the specific individual we serve?
They can certainly become a Medicaid enrolled provider, and they may be, but I'm not sure about the billing component. That would be Jen's wheelhouse.
So are you talking about like a specialty service, like an assessment or a consultation?
Correct, behavioral services. So,
okay.
If I understand, if I'm hearing this right, rates there would be a billing code, and there would be rates assigned for different kinds of services, case management being one, residential being other. So would behavioral services have a rate so that when the service provider provides that service, they can directly bill instead of having to go through the vendor agency?
So when it comes to consultations and assessments, any sort of medical services, they have to first go through our managed care organizations to see if the MCOs cover that service. If they deny the coverage of that service for the individual, then we need to talk with our Medicaid partners here at the department to see if that is something that the MCO should cover. And if they should cover, then we would work with our Medicaid partners to have an agreement or have them become a provider under the organization or not. The waiver provides a service if Medicaid does not provide it. So we will be sending out more information about that. We're working with Medicaid now to come up with a process to do that. But that's the way it's going to have to go forward. And so those providers may have to enroll with the managed care organizations who will then pay them. So
I'll kind of piggyback off that one. So we do therapy services. So we have a behavioral health staff that do, direct therapy services. We have our own Medicaid ID for a behavioral health group. Our providers are individually registered as rendering providers with Medicaid, and then also the MCOs. So that's how we bill certain services. Then there are the other services, which I guess is what my question would be, and it sounds like you're already looking into that. You know, those behavioral services that aren't covered by MCOs, that don't have a direct therapy code, stuff like training staff on behavior plans and things like that. So if I'm understanding correctly, you're working on that to see if that will be an MCO covered service, or if that's going to roll into the new IDs, right?
Correct, exactly. And that's where we rely on our Medicaid partners, because they know what the managed care organizations are supposed to cover. And they will push them to cover things if they're supposed to. If not, then we can have a discussion internally as to how we would be able to provide it on the waiver, and what that code would be. So as part of our modeling project, we're looking at identifying gaps that we're not sure that we have codes for, because we're not going to have a budget template where we can put stuff in different sections and then have it build under a code that we currently have. We need to identify everything that's provided and make sure that it's clean for an audit. Does that make sense?
Yeah, makes sense to me.
So like those behavioral services that you provide, we need to know what they are, as opposed to just saying, oh, it's a specialty service and we're going to bill it under X.
Mm-hmm.
So we just need to identify those things so that we are aware, and we can work with CMS through the waiver in to see if we can cover it and how we can then cover it. So
Jen, this is Anna. I'm going to piggyback off Mark's comments. So a big gap with Medicaid coverage in behavioral consults and services are for children that lack the quote unquote correct diagnosis. Kids have behavior challenges. It astounds me that there's a diagnosis required to get that support for families.
keep in mind that these are Medicaid services that are being provided, and it's the whole person that we're looking at. And I'm not a Medicaid expert as far as the managed care is concerned, and so there are codes for everything. You go to the doctors, there's codes for everything, and so we'll continue to work through these, but we do have to work in the system for direct bill that CMS requests us to do, and quite frankly, that everyone else in the department is using. So.
Okay, thanks, Jen. I know some of you heard from a voice, Kathleen Donovan. She is the provider enrollment manager at Conduent, and I work closely with her on the enrollments, and they're very instrumental in the initial screening of applications that come in and alerting us if there's issues that they're seeing, or they work with individual providers to try to get them through the process, whether it be the forms that they need to upload or there's information on the application missing. She has a great group of enrollment specialists that are out there trying to assist us in this process. So that number is at the bottom of this slide, and it's Medicaid Provider Relations Center. And you may hear from her if there are some questions regarding the applications coming through the system. Are there any other questions today regarding the presentation that we can clarify for you?
Hi, this is Michelle Donovan from Living Innovations.
Hi, Michelle.
Hello. I noticed there are a lot of questions in the chat. Will they be answered in writing somewhere?
So Jess, do you want to, are you looking at the chat? Do you want to give us some of those questions? I can't pull up the chat with my screen up.
Sure. Do you want to cover them now? I've captured them in an email also.
Okay, are there any questions that were in the chat that people would like us to cover right now? We still have some time if you want to do that.
I see a few that we didn't get to touch base on yet. I think we covered do we need to enroll each service location individually? We talked about that. If we do our own billing, does that mean we will no longer be charged the 2% on contracts, which now go to the area agency? And when does this become effective?
So Jen, they're talking about doing their own billing. Will they still have that 2% charge? Has that
That's
been decided?
not, no. You will not have to pay for billing unless you hire a third-party billing company to do your billing for you. And that price for the billing will be set by the company that does it. There are companies out there now that do it. So it'll be kind of like a competitive kind of process. So there's not a set percentage. I don't know who asked that, but is that on top of the 3% that you give to the agencies to oversee the budgets?
From Daphne TL, and I believe she meant to say that 3% area agency.
Okay, okay, thank you, Sudha. That's what I was wondering, but I wanted to ask.
Would you be able to share the third-party billers or examples of vendor softwares, like what are currently being used?
There are multiple methods being used. I'm not sure. I looked at Kathleen. Do we have any idea of what is currently being used out there in the system on providers, Kathleen?
As you say, Karen, there are many different softwares that are out there. And if you have a certain software that you're working with now, we can accommodate for almost all of them. I haven't come across one that we couldn't accommodate for. When it comes to the trading partners, that's a relationship with you and that that vendor or that contractor. And I wouldn't venture to tell you which one to use or suggest or anything. We do have trading partners that are enrolled today. When you're talking with your people, if you wish to go that trading partner route, when you're talking to them, you should ask them if they're already enrolled in New Hampshire Medicaid, and if they are, ask them for that trading partner ID so that you can include that in your enrollment. I would also like to just point out that the MMIS portal access enables you to do your billing yourself electronically right in the system, and you'll get that real-time adjudication. And it is a simple process, but how you handle your relationships for billing is totally up to you.
Thank you.
You're welcome.
So I do want to just review again about the case management only agencies. There is preliminary review done that it looks like that service is going to need to be licensed through health facilities. So we are going to try and get that decision final within the next week or so, because if that is what agencies will have to complete, then you will have to send in a health facility licensure form for them to do your inspection and finalize a license for you to provide case management. This is only if that is the only service you are going to be providing.
Karen, this is Erin Hall. A quick question in regarding licensing. So we currently have a license through facilities. Yeah. Will that one for SICE will be good to use for this also?
I knew that was going to come up because I know some of you already do, because you do dual case management. And that is a discussion that I had with Melissa in legal. And we have not come to that final decision yet, but we're hoping that it can be the same, Erin.
That would be nice. Thank you.
I'm going to work on it. I will try. It's just a matter of having a license. You have a license. You can give us a number. It just, we want to make sure it's for those who do CFI and do developmental services, so that you wouldn't have to get two.
Okay, thanks.
Mm-hmm.
Hi, Karen. This is Jeb Kurlop from Life Coping.
Hi, Jeb.
Hi. I have a question about, we have for CFI, we've already, Life Coping and it has enrolled with MMIS, and we are billing through MMIS. And so we've gone through that process with the getting the NPI number and the trade agreement. My question is this specific to agencies that will be working with in BDS with the developmentally disabled, or is this also going to apply to all Medicaid providers, including the CFI providers?
So all of our CFI providers, Jeb, are already enrolled, and they enroll as they want to provide services. So this is strictly for the BDS population. So you will have to complete, if you want to do case management for that population and bill directly for it, you would have to have a new provider ID under developmental services.
Okay, so then we'd have two provider numbers. We'd have one for this. Okay.
Yes.
All right, thank you.
You're welcome. Any other questions?
This is Kathleen again, Karen. So that's a good example of where you would want, why you would want to have the Medicaid ID on your claims if you're not going through the portal, but you're submitting them electronically otherwise. If you have that provider ID that's situated with that particular claim, then it will adjudicate much quicker and efficiently because you do have more than one ID.
And also it will prevent you from having a call from program integrity when we are doing claims analysis, because with that provider ID, we can actually see what you were currently reimbursed for under Medicaid using your provider ID and your MPI.
Hey, Karen, quick question.
Yes, Erin.
I don't see a choice under provider type as other.
We were concerned about that. So what are there any choices there at all that say other, or we thought we looked that up though?
Yeah, I'm on it right now. And
it's 099 is the code.
It says the closest thing would probably be not classified or unknown.
There you go, not classified or unknown. Thank you, Erin.
Okay, so use that one.
We'll use currently unclassified or unknown. That is the category that you're going to be selecting as provider type right now, if you're going to be doing your application prior to the implementation of the new provider type, which won't be until October.
Thanks.
Yeah, thank you. Thanks for that.
Yeah, thank you.
Hi, Karen. This is Carla with True Granite Service Coordination.
Hi. You went on mute again. Somebody did.
I'm testing out this space bar. I heard you can hold that down and use that. It did not work. So I'm curious about the license form for case management. You guys said that it's in preliminary right now and you'll know something next week. Is there any way to get on an email chain with that so we're up to date on what you guys determine?
Yes, so Jess Kennedy, who coordinates these meetings, hopefully has an email chain. I saw quite a few email addresses. So what we're going to do is when we are ready to provide the final guidance from the department, we will put it out there on the website as well as send it out by email.
Okay, thank you.
You're welcome.
This is Diane. If an entity does their application now and uses the unknown category, do they then have to redo? How much of it do they then have to redo to change their category when the new?
Don't have to redo anything. We've already set it up in the system that once that application comes in with that, we do it behind the scenes for you once we actually have the provider type and specialty.
Thank you very much.
You're welcome.
And this is Kathleen again. It would be helpful when you are uploading your documents to your application. Perhaps you could upload a little note that says this is for the developmental services so that we can immediately just go through it all correctly as developmental services and not have to contact you for that reason.
Karen, did you want a few more of the chat questions?
Sure, Jess, go ahead.
Do respite providers need to be screened on the OIG list monthly?
Oh, definitely. Definitely. That is a hot topic right now in program integrity. So if you have members that are self-directing and they want to hire their own respite providers, they must go through a screening process. So it would be the agency's responsibility to do that if you're going to be billing for that service.
Will providers manage their own pending claims?
Pending claims. Can whoever asked that question give us a little bit more what you're talking about?
Ray, can you give detail on that?
If a PA isn't issued, who's going to, you know what I mean? We're not collecting anything for it until a PA gets issued.
That's correct. So my understanding, and Jen will chime in please, is that there is going to be a mechanism set up for the service authorizations to continue to be entered by the area agencies. And that is going to be a later training down the road.
That's correct. That's correct, Karen.
There we go.
That is absolutely correct.
We are not ready for that yet.
No, but it's coming. It's coming with MMIS, and
yes.
And so area agencies will be later on this year will be entering their own service auths into MMIS. We call them prior authorizations in the BDS system, but in MMIS, they're service auths. It's the same thing, it's just a different name. So just so we have the same lingo. And area agencies will be responsible for putting up service auths for all services going forward for the individuals that they receive the Medicaid administrative rate for.
So that is another process that is going to probably have to have an initial training to the agencies and providers. So that will be coming down the road. Did that answer your question?
Yes, thank you.
You're welcome. Go ahead, Jeff.
Who will bill private insurance for ESS before billing Medicaid as they're the payer of last resort?
So the responsibility and program integrity, the responsibility is the providers. The provider that is providing the services for ESS needs to bill the commercial insurance receive a denial from the commercial insurance, and then submit the bill to Medicaid. And if you do not follow the process that we have written in the administrative rules, there is, you know, repercussions that could happen if you do not get that denial from the primary insurance. Now, if you are seeing the child and it's an ongoing, and it's not, you know, you check the insurance upon taking the child on, and then the administrative rule, you want to check and see what your timelines are, because if the service keeps going month after month, you probably don't have to check it every month, but there are certain timelines that are within the administrative rule that tell you how often you need to do that TPL check. Did that answer your question? Okay. Go ahead, Jess.
Someone is asking, if we enroll as a non-billing provider, what is the process to change to a billing provider?
Okay, so I need an example of why you would enroll as a non-billing provider. So that means you want to enroll to get a Medicaid provider ID. For what reason? Because all groups are going to be a billing provider. Only those non-billing individuals, there's not going to be very many of them, I don't think, that you will be asking them to enroll as a provider, because you're going to be paying them directly.
So every provider is going to be a direct bill provider. They can choose to directly bill themselves or have a third-party biller bill for them.
So if you use an individual who is not a group, it's an individual, and that individual provides a service, you're going to be billing for that service, not that individual. So if you hire somebody to do respite, you're going to pay that respite provider. They're not going to bill Medicaid directly.
Hi, this is Kathleen again. Is it helpful to think about the fact that everybody's going to be enrolling, and you're all going to be enrolling as a billing provider? Whether you're an individual billing provider or a group provider depends on what you're putting in for your financial information. So if you're using your social security number, you would be an individual billing provider. If you're using your FEIN or tax ID, then you would be a group billing provider. And if you are already enrolled in New Hampshire Medicaid right now as a non-rendering provider, not a non-billing provider, then you would need to identify what ID you're enrolled under, and we'd work with you on that. And as Karen's saying, she doesn't understand. I don't understand why you would already be enrolled as a non-billing rendering provider. Why that would be, unless maybe you're, say, so you identify why you're a non-billing rendering provider today in New Hampshire Medicaid, and then we would be, we'll work with you as to what you have to do for this.
Right. Thank you, Kathleen. Yeah. Any more questions, Jeff?
Yes. With regard to the timing and rollout of the application and billing, could you please take into account many smaller providers do not have multiple support staff to assist in preparing the application, etc. And we are working 24/7 with DPH testing of staff and residents, managing residents in our stay-at-home model for LTCF, and do not have extra time during this pandemic. I think they're concerned about the timing of
So we certainly understand everybody has additional job duties that they're trying to perform right now. That's why we wanted to give this overview in September, so it gave you time so that you could go in and start, because you can start an application, but it doesn't mean you have to sit and finish it with everything that you need. as long as you keep your application tracking number, which is given to you when you first start out in the application, you can go back into that application and continue as you have the availability. Our goal was we would like to have as many have their applications started and working through the process so that we have an idea. I mean, we're trying to manage workloads too on our side. So we wanted this, and Jen, correct me if I'm wrong, I think we were striving for January of next year. Is that where we were?
Yeah, excuse me, yes. We want everyone to start doing it because it is a process, and sometimes it takes a while to get applications in and people enrolled. And we have Kathleen with Conduent, we have Karen in the program integrity area, and BDS staff, many of which are on this call, that are at the ready to help you do this. And so we want to make sure that it's a smooth process as possible and that we are giving you enough time to get ready to direct bill and have the appropriate time you need to either set up a back office if you want, however you choose, or to get that third-party biller. Either way, you will be billing. You will be a billing entity. So that's why we're doing it. That's why we're doing it now, and we want to work with you to make sure it's done. We don't want to wait until, March and say, oh, well, we decided to do this, but, we want to do it now. Get it done now. And that way, it's just off our plate, and then we can focus on the other things that we need to finalize before the July 1 start. And I will too say that I appreciate, the collaboration with Conduent, our DOIT, MMIS staff, as well as Karen's staff to do this. We've been meeting through the pandemic. Even though we weren't able to meet with you, we did meet. And on those calls we had from Conduent and all the groups from different aspects of MMIS, enrolling, claims, everything, to make sure that we're not missing anything as we put this in the system. So I appreciate their support as well.
Thank you, Jen. Well, that's what we're here for. We want to help. So, please reach out to any of us once we give you that contact list to try and support you and help you through this process. Anything else, Jess? We got a couple more minutes.
This is Diane Martinez. I have a quick question. No, it's a question I have about, it has to do with PDMS, Participant Directed and Managed Services. Currently, we have one billing rate per month based on the total amount. Like if a person has some day service, they have some residential service, and part of their case management, it's all combined into one rate. And we usually bill that every month. We don't have units, like we have 12 units a year, so everything's broken out that way. So if someone has they have so many hours a week with a residential vendor, would that vendor still submit their billing to us and then we bill it as one rate? Or would the vendor bill that separately as their own entity?
Diane, this is John. That's an awesome question. I'm glad you brought that up. So PDMS is not a service that is provided. It is a method of delivering a service.
Okay.
So Sandy, I got it right this time. So we're all learning, people. I mean, everybody, we're learning, okay? So
yes, thank you, Jen.
So there will no longer be a 112 billing. You will be billing under PDMS for the specific service that will be rendered. So if it's day, if it's case management, if it's SCPs, CSS, whatever it is, they will be billing it. Whoever provides it will be billing that separately for those services, as is outlined in their service agreement. So it will look differently. It will not be a blended combined 1/12 billing anymore. It's going to be actual billing based on what's provided.
That's currently what we do. We get a bill each month from the vendor, whatever vendor it is, and based on what they have provided for service, we take that and we bill it. We bill actuals from the Moore Center.
Yep.
Bill 112. So I guess what I'm saying is they're going to bill directly. They're not. It's not going to be one. It's not all going to come to one place and then be billed.
It depends. So if you're looking at a respite provider, Diane, respite providers will not be enrolled. They will be contracted by you to provide a respite service on behalf of the individuals that choose the delivery, the PDMS delivery.
Okay.
So then you would bill that respite service.
Okay.
But if it's a day service that's provided by someone that's enrolled, then they will choose to bill it themselves or have someone else, a third-party biller, bill it for them.
Okay.
Does that make sense?
Yes, it does.
Okay. Thank you. I appreciate you bringing that up, Diane, because I think that is a very good point and a distinction of what is currently happening in the system and what will be happening.
Thank you.
Thank you.
Phillipson, if I can add something to that, and I know this meeting is coming to an end and we have a ton to talk about. Authorizations, when we have a PDMS person, we have the PA is put up under the provider ID of the area agency. And so everything rolls up that way. So if we're talking about having a day provider direct bill for a PDMS, a service that's under a PDMS program, does that mean that the prior authorizations are going to have to be line items out on what providers are providing which services?
Yes, just like in traditional, correct.
Okay. Thank you.
Yep.
So we're coming to the end of our 2 hours here. I want to thank everybody for your participation. We had some great questions, great conversation. As I said in the beginning, Jess did get this to record for us. So for those that missed it, there will be a recording. And also any questions that were not answered that were in the chat, we will put those together and send those out. Give a few days. We'll do the PowerPoint as well as a contact listing. And we will get that out to all of you that provided your email addresses in the invitation. I want to say thank you to everybody. Thank you to the department, to the program area, Conduit, Kathleen Donovan. We'll all be here to kind of help you through this process. And we appreciate you being on the training session today.
All right, thank you guys. Again, I appreciate it. And we'll be sending out specifics for the rate modeling soon, and we'll regroup next month. Have a good weekend.
Thank you, everyone.
Thank you.
Bye-bye.
Thank you. Bye.
Thank you, Jess.
Karen, I'm going to give you a call, okay?
Anybody has any additional questions they want submitted to the Bureau, just send them to me. My email address is in the chat and also was connected to this. So any more questions? I'm trying to get to the right people.